Good morning, good afternoon, everyone, from wherever you are attending this webinar. Welcome. The summer of 2023 witnessed the Northern Hemisphere's hottest temperatures on record, leading to unprecedented wildfires. These fires significantly impacted air quality across vast regions of the US, with Canada experiencing its most severe fire season ever. This extreme heat combined with wildfires marked a stark reminder of our changing climate. Today, I'm honored to be hosting two distinguished experts in the realm of extreme heat and wildfire health effects. First, let me introduce Dr. Gregory Volenius. Dr. Volenius is an environmental health professor at the Boston University School of Public Health and the director of the new BUSPH Center for Climate and Health. He's also the co-PI of the new NIH-funded Climate Change and Health Research Coordinating Center, also known as CAFE. He's an environmental epidemiologist committed to reducing the adverse health impacts of climate change through research, training, and engagement. Prior to joining the faculty at BU in 2020, Dr. Volenius served as Associate Professor of Epidemiology at the Brown University School of Public Health and Director of Brown Center for Environmental Health and Technology. Prior to that, he earned dual doctorate degrees from the Department of Environmental Health and Epidemiology at the Harvard School of Public Health. He has published extensively on the cardiovascular effects of ambient air pollution, contributed to the US EPA's 2009 Integrated Science Assessment for particulate matter, provided invited expert testimony on this topic before the US House of Representatives and the US Senate, and served as a co-author of the 4th National Climate Assessment of the US Global Change Research Program, also known as USGCRP. He's the 2019 winner of the ISE Tony McMichael Midterm Career Award. Next, we have Dr. Jennifer Stowell. Dr. Stowell is a research scientist in the Center for Climate and Health at the Boston University School of Public Health and currently serves as the secretary of AGU's GeoHealth section. Jennifer earned her BS in physical geography from Brigham Young University and her PhD and MPH from Emory University with Dr. Yang Liu's group. Her research is at the nexus between climate, air pollution, and human health. She utilizes spatial and epidemiologic methods to examine the adverse effects of climate change on human health. Her continuing research is focused on expanding our understanding of extreme heat, prescribed fire, and wildfire smoke exposure on pregnancy and birth outcomes. Her work has been featured in multiple high-impact environmental health journals and numerous news outlets, and she's an author on the Lancet Countdown in 2022 and 2023. Some quick reminders before I hand the floors to our speakers. Please make sure you have your microphone and cameras off during presentation. This webinar is recorded and the recordings will be posted on the GeoHealth YouTube channel. I also encourage you to use the chat feature to ask your questions. Thank you, and Dr. Volenius, the floor is yours.
Great, thank you. Thank you for the invitation to be here and for the nice introduction. Let me share my screen. All right, you can see my screen okay? All right, great.
Yes, perfect, thanks.
All right, so first I want to start off by acknowledging the many people with whom this work wouldn't be possible. These are some current and former members of my group, and as you'll see from the papers I share, there's a large network of collaboration across several leading institutions. I also want to thank our funders, again, without which this work couldn't be done. And those asterisks there next to Google and HEI imply that I also have an external consulting relationship with those organizations. All right, so as you all know, climate change affects us all through a variety of changes in the environment, including more severe and more frequent extreme heat events, and as well as extreme cold, heavy rains, floods, drought, and so forth. And these have a variety of health impacts that are really well described in the literature and in several review documents, including the National Climate Assessments report specifically for the US. So today I'm going to talk about extreme heat and our work in that area. And you know from the news that extreme heat is a very real problem, even in the US as a high-income country. And of course, this year was particularly hot across much of the country, and we can talk about that at the end. But here's just an example from the 2021 Northwest Heat Dome, which this report from our federal government attributed that there were 250 deaths in the US, more than 400 excess deaths in Canada, and hundreds of heat-related emergency visits reported across several states, as well as in Canada. And oops, there we go. And we just took as one example from real data of the number of emergency department or ED visits in response to these events. You can see the pink bars here are the period during the heat event in both Portland, Oregon, and Seattle, Washington. And you can see that maybe there's a small increase in all-cause ED visits here in Portland after the event, in the days following the event. Maybe a subtle shift during the event in Seattle. But really what you see is an increase in ED visits that we think are heat-related or heat attributable by different definitions. And the more specific definition you make, so these are the ED visits specifically for effects of heat and light or exposure to excessive natural heat, you really see an increase in those. So we do see an increase in emergency department visits, but not necessarily a wholesale increase in all-cause ED visits. And just to put some numbers on that, here's the incidence rate ratio depending on the definition that you use of excess ED visits by cause, as in each of the two cities. You can see that in Portland and in Seattle, when we have a specific definition of heat-related exposure, you see a really big relative risk increase there, but a visible but less pronounced relative risk with a broader definition. So that's just to say that excess heat is a recognized threat to public health. In the US, more people die of extreme heat each year than in any other meteorologic event. That's been well documented. And there's still people dying and there's still people suffering. And so this really implies that we've made insufficient progress towards preventing heat-related illnesses and deaths. People are still suffering the effects of heat despite this very large body of knowledge. And that really suggests a lack of translation of this abundant scientific knowledge into public health action. So I just want to pause a minute to show you the type of study that is now very common in the field. This is the seminal work by Antonio Gasparini and colleagues in a first paper where they looked across hundreds of cities across the world and documented the association between temperatures across the temperature range on the x-axis and the relative risk of mortality on the y-axis. And you can see that, this curve, interestingly, has a common shape everywhere, but it's a slightly different shape in terms of how steep does the curve go up at extremes of temperature, and also where that inflection point or this temperature of minimum mortality is. So this has been shown now, in a variety of studies in a great many places across the world. And this highlights that the effects of heat are really going to be very local because of the difference in these exposure response functions by location. To some extent, we have to, think about what are the local health impacts of heat within each community. So these very large studies, nationally and globally, really show that extreme heat is associated with higher rates of death and hospitalization. And importantly, as you saw in the last graph, it's not just these episodes of extreme heat, although that's what we'll focus on today, but also moderate temperatures, which happen, of course, much more often than extreme temperatures, are also associated with these higher rates of death and hospitalization. We know that vulnerability varies by personal, housing, and neighborhood characteristics. And of course, the US has already warmed substantially and is projected to warm further through the end of the century. So while this is all true, what policymakers actually need to know at the local level is what are the health risks associated with a given climatic hazard, in this case, extreme heat, who is at greatest risk or most susceptible, what local actions can they take to protect public health, and do these actions actually work to reduce risk? So let's start with the first two is, what are the impacts of extreme heat and who is most susceptible? So we can do this across the country. Surprisingly, as late as about 2020, so just about 3.5, 4 years ago, there wasn't good estimates of how many people die of heat in the US. And this was a major shortcoming because it helped, knowing this number helps us understand the magnitude of the problem. So using data on mortality through 2006 in the US in about 300 counties, which represented at the time about 60% of the US population, we thought that there were about 5,600 excess deaths attributable to heat each year. Of those, about 2,300 were due to extreme heat. And now this isn't the full country. This is, the 300 most populated counties. So that puts the total number of deaths due to temperature to about 10,000 deaths a year across the whole country. That's probably still an underestimate, and more recent reports suggest that it's, definitely 10,000 or higher in terms of the excess deaths per year attributable to heat. You can also, using these methods, show how the excess deaths, the rate of excess deaths varies in different parts of the country. So here are the country divided by regions as the National Climate Assessment does. And you can see that how much the risk can vary even with, both between regions and within a region. So I want to pivot to some of our work on emergency department visits. So this is a series of studies we've conducted using a very large database known as the Optum Labs Data Warehouse. And this is for about 130 million individuals across the US over time with commercial or Medicare Advantage health insurance. And so you can see that urban areas tend to have more people and more emergency department visits. So more populous counties are overrepresented, and as well where this particular database is not nationally representative, but rather it's where the people with these policies happen to live. And so doing the same type of analysis, again, pioneered by Antonio Gasparini and colleagues, we can apply that to the emergency department data. And here we show percentiles of warm season temperature on the x-axis, so ranging from kind of cool summer days to very hot summer days, and the relative risk of either all-cause emergency department visits or heat-related emergency department visits. And you can see now we're just looking at the effect of heat, so we don't see the U-shaped response because this is warm season only, but you can see that you have an increase in, again, both of these endpoints, but that the magnitude of that increase is much stronger. That association is much stronger for more specific outcomes like heat-related disease. And because this is such a large database, this particular analysis had about 20 million ED visits, I believe. And so you can look stratified more finely by types of cause of ED visits. And here you can see that we see an association between ambient temperature, warm season temperature, and renal disease, and also mental disorders, but not specifically for cardiovascular disease or respiratory disease. So this starts answering that question of what are people being impacted by and who's at risk, is defining the populations that we might need to help most. One really interesting finding that was sort of contrary to our expectations is that the excess relative risk and the excess absolute risk didn't vary that much across the age range. So we looked at, in the previous figures, these were adults of all ages, so 18 and over. And you can see that although there is some variation in these rates by age group, that this isn't purely a risk that's facing the elderly. So we are all at risk across the life course, and men and women had relatively similar risk profiles in the big picture. And this is some fantastic work led by my colleague Amruta Nori Sarma, also at Boston University. And really, she dug into the relationship between ambient temperature and ED visits for mental health. You can see the range of mental health conditions considered there on the table on the right. And so what this really highlights is that we're not just talking about dehydration and heat stroke or heat exhaustion as the primary endpoints, but really a broad spectrum of physical and mental health endpoints. So this is also great work led by my co-presenter today and colleague, Dr. Jennifer Stoll. And in the same database, looking at ED visits in children rather than adults. And you can see that children overall are also at risk, and that this varies somewhat depending on the age group between young infants being at the lowest risk and adolescents being at relatively higher risk. So again, we're seeing this picture that there's a spectrum of risk across the life course, and it's not specifically to one age group or another. We did similar work because this is a database of individuals with commercial health insurance or Medicare Advantage. We wanted to see that if the results would be similar in a database of all comers rather than insured individuals. And here, this was great work with our colleague Ari Bernstein, who's now at the CDC, but at the time was at Harvard University and Boston Children's Hospital. And this was using a data set of emergency department visits at 47 US children's hospitals. And you see similar results there that for heat-related illness, you can see at the top here, there's quite a pronounced risk. And then for all-cause ED visits were also associated with episodes of extreme heat. But because of the size of the data, you can also see that there's a range of other causes that you wouldn't traditionally think of as being related to heat that were also seem to be more common on days of extreme heat than on other warm season days. Okay, so this tells us a lot about who's at risk and who's most susceptible. So what can we do about that? And in the US, the National Weather Service issues heat advisories and excessive heat warnings when the heat index typically is forecast to be high. What we mean by high varies from location to location, and there's not really great evidence for what's the optimal threshold for issuing these heat alerts. And when they're issued, heat alerts may trigger activation of a local heat emergency response or a heat action plan. So based on some of the early work we did around 2016, we actually worked with the National Weather Service Regional Office for New England and documented that a substantial number of emergency department visits and deaths were apparent at levels even before a heat warning or a heat advisory were issued. And so based on that evidence and through collaboration with them, they went ahead and changed the threshold at which to issue heat advisories for all of New England. So the green region here shown in New England adopted a lower threshold for issuing heat advisories than they previously had. And so this seemed like a cause for celebration and something that hopefully would protect a large population across New England. But the question is really, how effective is issuing a heat warning? And there's actually not that much evidence on that topic at the time. And so we set about to study that, and I won't go into the details here, although I'm happy to talk about it. But essentially, we published one small initial pilot study in 20 US cities where we were able to get the data through 2006 on both mortality and the frequency of heat warnings. And what we found was that fewer people did not die on a hot day with a heat warning compared to a day that was similarly hot but didn't have a heat warning. So there's no consistent benefit in that study. And so then we realized the limitations of that study in terms of it was only 20 cities, it was a limited time period, it was kind of long ago. So we repeated the study with a larger study base shown here. And interestingly, there we found similarly for mortality that there was no mortality benefit of issuing a heat alert on two similarly hot days, one with a heat alert, one without, but it did seem to increase the risk of hospitalization amongst Medicare beneficiaries for heat stroke and for fluid and electrolyte disorders. So perhaps, one hypothesis is that although we're not helping people not die, we are encouraging people that might otherwise suffer in isolation or suffer at home to seek medical attention. Okay, so back to the problem. So we recognize that heat poses a significant threat to human health. There's some remaining questions about who's most susceptible and what interventions are effective. There's not been complete translation of this knowledge into public health action. And so when a public health official from a local jurisdiction comes to us and says, what should we do? We don't really know the answer to give them. And so it's really great to see. I'm just going to point to a number of efforts that are not mine, but that I want to sort of just highlight the great innovation that is currently happening around the country and around the world to try to reduce the adverse impacts of extreme heat. So this is a prototype from the National Weather Service in partnership with the CDC, where they're categorizing days not in terms of how hot they're going to be, but in terms of the projected health impacts of that heat. So this is moving from a model of heat warnings to heat health risk warnings. Really interesting idea. And California liked that approach and has actually passed a bill that was signed into law, I believe, 2 years ago, to launch the nation's first heat wave ranking system. And what's interesting is, again, that this is ranking heat waves not in terms of how hot they are, but in terms of their projected health impact. We don't exactly know how to do this well, but there's lots of efforts trying to design such a system. In other parts of the world, there was in Seville, Spain, in 2022, heat wave Zoe became the world's first named heat wave. And the research question there is whether naming a heat wave, as we do hurricanes, actually increases public awareness of the potential threat to health from such events. And we're collaborating on some research with the Atlantic Council and the Arch Rockefeller Resilience Center to see if, in fact, this naming of heat waves was a message heard by the public. So I want to end with this. This is a really great way to think about both the components of an effective response to any public health threat, but specifically here to hot weather, and really calls for a research agenda that's focused on defining dangerously hot. What do we mean by dangerously hot weather? How dangerous is dangerous enough to take public health action on it? How well can we forecast those events? Who's at greatest risk of harm? How can we intervene to reduce the health impacts in the most vulnerable? And then we need to be able to continually evaluate the effectiveness of those interventions so that we can do it all again and optimize these systems to truly reduce the adverse health impacts of extreme heat. I'll finish with letting you know that NIH, as part of their Climate Change and Health Strategic Initiative, has funded a new research coordinating center that's based at Boston University and the Harvard School of Public Health, with myself, Amruta Norisarma, and Francesca Dominici being the three co-PIs of this effort. We just launched a couple months ago. We're very excited to move this forward and to try to convene, accelerate, foster, and expand the community of practice around climate and health. And I encourage you to look at the website that just launched last week. It's at climatehealthcafe.org, or you can scan that QR code to get you there. So with that, I will pause and thank you very much for your time.
Thank you so much, Dr. Villanius, for a great talk. We move to our next speaker, Dr. Jennifer Stovall.
Slides look okay?
Yes,
Great.
it does.
Great. So as mentioned, my name is Jennifer Stoll. I'm currently a research scientist in the Climate and Health program at Boston University School of Public Health. I earned my MPH and PhD with Dr. Yang Liu at Emory, and I've continued my work here at BU in climate change and health, mostly focused on focusing on the adverse health effects of wildfire smoke exposure. So as you may be aware, climate can affect the quality of our air in multiple different ways. First, it can happen through direct routes. An example of this would be the impact of increased heat and sunlight on the formation of ozone. Ozone is formed in the atmosphere specifically by heat and sunlight. And so increased heat could potentially worsen our air quality due to ozone. And then indirectly, climate does not actually affect the creation of particulate matter, but it can influence things that put particulate matter into the atmosphere, like wildfire activity. And so those resultant wildfires can contribute to our worsening air quality and increase our health risks associated with that. So wildfire activity has been steadily rising in recent years. This is especially true in the Western US, where fires have increased in number and frequency, as well as size and severity. And this has been illustrated by the California wildfire season of 2020, where 5 of the 20 largest fires in the state history occurred just in that year alone. So here we're looking at a couple of different infographics looking at that increasing wildfire that we've been seeing. So on the left, this is a figure put out by Climate Central showing kind of the general trend of increasing number of fires that are larger than 1,000 acres across the US. And then on the right, we're looking at something that was part of the NCA4. This is looking at both the factual and counterfactual of the number of wildfires that have occurred due to climate change. So as you can see, they're both expanding quite a bit. And with the counterfactual versus the factual, wildfires with climate change have almost doubled the number of acres burned in the US. So, and then climate change obviously complicates this matter. So climate can be affected or can affect wildfire activity through several different mechanisms. And to illustrate this, we can refer to what is known as the wildfire triangle. So in order for a fire to occur, there's 3 important elements that need to be present. These 3 elements are heat, or a source of ignition, fuel, and a source of oxygen. And in multiple ways, climate change can actually increase the chances that these elements will be present. For example, fuel is heavily reliant on both precipitation patterns, fuel is heavily reliant on shifting precipitation patterns as well as the frequency of drought. Increased oxygen from increasing wind speed and temperature differentials between land and sea can be influenced by climate change. And then also, as Greg pointed out, heat. This increasing frequency of heat waves and the frequency of lightning strikes all contribute to the potential for a wildfire to occur. So we're looking here at the number of annual wildfire weather days from 1973 to 2022. This is the average number of hot, dry, and windy days during that period. And as you can see, much of the US is expected to increase in the number of days per year where a wildfire could occur. And then finally, a key thing to keep in mind with wildfire research is that estimating the exposure is really challenging. So first of all, we don't have a way of estimating personal exposures. We also have the issue that our monitors do not have the capability of separating out wildfire smoke PM2.5 from ambient. And so previous work has looked at total PM2.5 with fire day indicators. And now kind of the new approach is the chemical transport models. However, they're both very difficult and expensive to run. And so the availability of the data using chemical transport models is it still is in its infancy. So, and as was mentioned, before, 2023 has been a year of records, including wildfires. And the Northern Hemisphere has seen record-breaking activity in multiple countries. So these headlines are just a sample of the fires that have been in recent news. But then a key thing to be thinking about is that while our wildfire season is starting to kind of turn down, the global south, parts of the global south, their wildfire season is just getting underway. So it's evident that climate is impacting fire. And just this past week, a manuscript was published in Nature showing that wildfire activity has begun to negate some of the clean air advances that we've actually made in the past. So this map shows the state-by-state trends in particulate matter concentrations from wildfire smoke. And this is also looking at counterfactual versus factual. So the let's go ahead and look at this is for the entire contiguous US. So the blue line is what would have happened without smoke, and the black line is observed. And so as we see, we're starting to see kind of this divergence and kind of more of an increasing trend in our PM 2.5 air quality levels, and that could be related to wildfire smoke. So one of the important things to keep in mind is this idea of the wildland-urban interface, or the WUI. It's a zone of transition between land that is unoccupied and human development. And it's kind of the point where structures and human activities start to mingle with fuels in wildland forests or vegetated fuels. So the individuals that live within the WUI are considered a high-risk community. And the WUI is actually growing at an alarming rate, about 33% increased area just in the 2 decades from 1990 to 2010 alone. And it was an estimated 20 million housing units were in the WUI in 2020. And this map here shows the number of houses by state relative to the total houses. And so as you can see, a lot of the areas that are impacted either by wildfires or prescribed fire actually have quite a high percentage of houses that are now in the WUI. So why do we care about the WUI? Well, just dial it back a couple of years. I'm sure you all remember the Camp Fire in California that happened in November of 2018. This was a human-caused fire by PG&E power lines. The fuel source was extremely dry, late fall foliage. And then in California, in the late fall, there's winds called Santa Ana winds that are hot, dry winds coming off the mountains towards the ocean. And this coincided with that fire and really helped to drive the flames and help it to spread further. And so it incinerated several cities, burned over 150,000 acres, and there were 88 fatalities that occurred as a result. And then another thing to keep in mind is about 84% of wildfires in the US are caused by human activity, either through direct ignition or through our energy infrastructure. So here on the right, we're looking at a picture that I took when my family was vacationing in 2017 near Bryce Canyon in Utah. And it was a very high-risk fire day, but an individual decided to use a blowtorch to burn some leaves in his yard and started a very large fire that lasted for several weeks. So the thing that we really focus on for the most part is the particulate matter in wildfire smoke. However, there's several different toxic compounds that we're just starting to learn more about their impact specifically on health. So the particulate matter that we care about the most is PM 2.5, which is any particulate matter less than 2.5 microns. And the reason for that is that it can actually travel fairly deep into our respiratory system. And once there, it causes inflammation and additional damage to the lung tissue. And then, as you can see here in this diagram, there's actually a shared membrane between the respiratory system and the circulatory system. And so some PM2.5 is also able to kind of cover or cross that barrier and then get into the bloodstream and potentially cause additional health effects above and beyond respiratory. So the people that are most affected, children, because they have biological differences in respiration. Their respiration rates are much faster, and they also tend to spend a lot more time outdoors than adults. We also are concerned about the elderly. They tend to live in older homes that may have insufficient ability to filter out the PM2.5 from the wildfires. They may not have AC. They have less mobility and aren't necessarily able to quickly and easily leave an area because of wildfire smoke. And then some elderly individuals suffer from lower education that can also contribute to kind of their understanding of their risk. We're also concerned about pregnant women and infants, specifically because there's some very important developmental windows during the prenatal and postnatal period. And pregnant women especially could be at risk because pregnancy might be looked at as kind of an underlying condition for them during their pregnancy. And then we also are concerned about outdoor workers as well as unhoused individuals. Outdoor workers tend to be paid by the hour and often don't have the privilege of taking vacation days or sick days with pay. And so not going to work due to a wildfire smoke event is probably not an option for them. And then lastly, we also want to be concerned with individuals who have previous conditions like COPD or heart disease and asthma. So what is known? We know that wildfire activity is increasing. We think that high temperatures and droughts are contributing to that increase, and those trends are expected to continue. And then smoke PM2.5 has been linked to several different outcomes for our health, including the ones we mentioned, as well as low birth weight and premature birth and mortality. However, there are multiple understudied populations, like we just talked about. So there's a lot more research that needs to be done. So there is a long way to go. We first need to do a better job at estimating personal exposure. It's also difficult for us to separate out the individual pollutants within wildfire smoke. And there's also limitations to our modeling methods. We also know that there's a contribution from climate change, but understanding that magnitude is something that's very important for us moving forward. We also, in conjunction with that, need a better understanding of what the future burden might be for planning and policy purposes. There's also little that we know about the effectiveness of some of the preventative measures that are out there. Generally, when there is a smoke event, individuals are told to stay home, turn on the air conditioning, but not a lot is known about how much of that smoke can actually get into an individual's home, either with or without air conditioning or air filtration running. There's also several other outcomes and vulnerable populations that need a lot more work. Mental health, pregnancy, reproduction, and childbirth. We talked about children and outdoor workers, as well as unhoused individuals. And then another thing that I would love to see more of is more global research. So we see a lot of information about Europe and the US and Canada, but very little is known about some of the areas across the world that actually have pretty significant wildfire activity. And so it would be great to see some more of that happening so that we can better understand some of these other populations, especially the vulnerable populations in those countries. So just to give you a smattering of some of the recent studies that have come out in the last few years, so this first one is looking at some new information as far as schizophrenia is concerned. It was linked to lower lags of 0, 1, and 0 to 1. And then another interesting thing that we saw here is with cardiovascular disease. So with cardiovascular disease in the literature, there's only about a 50% agreement as to whether wildfire smoke actually induces cardiovascular disease or not. And so this was actually very interesting here because a lot of the research looks at shorter lags for our cardiovascular outcomes, but this shows a potential effect at much longer lags over 7 days. Another study came out looking across the US at mortality in the United States and showed that a lot of the areas where the highest mortality is attributable to wildfire smoke tends to be in the areas that are expected to have increased wildfire smoke activity in the future. There's also another paper that came out recently looking at the associations between smoke and preterm birth in California. And some pregnancy complications were also actually linked to exposure in this study. So we're looking at that very important population of pregnant women, and we're seeing adverse outcomes both for pregnancy complications as well as birth outcomes. So in the last few minutes, I'd just like to give a very brief snapshot of some of the current projects that I'm involved with. First of all, I'm working on a project looking at wildfire exposure in California in multiple age groups, and also looking at major categories of disease as well as specific outcomes. So on the right, we can see the results of our work in adults from 2012 to 2019. Wildfire smoke was associated with increased risk of an ER visit for any cause, as well as for asthma and COPD. And then we estimated the increased risk we also estimated increased risk for pregnancy and childbirth outcomes, as well as external factors. So our next steps are to look for effect modification of this increased risk by subgroups of the population. We've already begun looking at age, sex, and race, but we are hoping to use some relatively new data looking at the prevalence and usage of air conditioning, as well as looking at some of the community characteristics that might make an individual more or less vulnerable. And then finally, we're planning to repeat our analysis in children. Kind of shifting gears a little bit, talking about a different type of fire. One measure used for fire prevention is to practice prescribed burns to remove some of the fuel that can help wildfires spread. So these are small, purposeful fires that are done under controlled conditions, generally on days with high relative humidity and low winds. However, very little is known about the magnitude of the health impact from these fires. So we've teamed up with a group from Georgia Tech, and we were awarded funding from the Health Effects Institute to study this exposure in multiple southeastern US states. We're also working on a proposal to estimate the risk of pregnancy and childbirth complications associated with smoke exposure. So we're teaming up with the PIs of the Presto online pregnancy cohort, and we plan to investigate a variety of outcomes in pregnant women and their fetuses. And so we've recently procured funds to start generating some of the preliminary data that we need in order to put in a proposal for a larger NIH grant. And then finally, another project is underway to evaluate the impact of the Canadian fire smoke events on the Northeast. from this past year. We're in the process of developing an approach to quickly model wildfire smoke specific PM 2.5 using information from AirNow. And we hope to be able to actually potentially build a tool that could be used to estimate smoke PM 2.5 exposure within days of a fire event. And then we hope to be able to utilize the health data from the Optum labs that Greg spoke about, which is a large data set of several individual, or over 100 million individuals across the US. And we hope to be able to look at the increased health risks that might have resulted from this exposure. So in conclusion, I just want to acknowledge some of the folks that I am working with on each of these. So looking at the wildfire in California, several individuals, including Greg, are helping with that. Greg is also involved with the wildfire in pregnancy, as well as the prescribed fire. And then I'm working with folks across BU, both within our department and in the Department of Earth and Environment, looking at that smoke in the Northeast and the potential for predicting the health impact due to that. And with that, I will end and turn it back over to Azar.
Well, thank you so much, both Dr. Wallenius and Dr. Stoll. That was a great talk, and I learned a lot, as usual. Thank you. So we'll open the floor for questions. Please, you can unmute yourself, or you can ask your question in the chat. Since I don't see anything, I will start with one question for both of you. So how did the long-term exposure to such conditions affect chronic disease or conditions, both for the heat wave and wildfire?
Yeah, I can start. I think for heat, there's sort of two separate questions embedded there. One is, if you have a very pronounced heat wave, how long do those impacts last? So typically we think of the excess deaths and hospitalizations or emergency department visits from an acute heat wave being primarily at the same time and maybe lasting 1 to 2 to 3 days later. But we haven't really looked to see if there's longer term health impacts than that. There don't seem to be for mortality, but maybe there are for other endpoints. And a separate question is, does living in an area that is exposed to frequent heat waves, or in a part of the city that is in the urban heat island, so it's consistently exposed to slightly higher temperatures, what are the impacts of that on various health endpoints? And again, there's some research in that area, but it's really hard to disentangle the social factors that create those conditions in the first place from the actual consequences of the exposures. And Jen, maybe you want to comment on wildfire smoke?
Sure. So unfortunately, it's a very similar answer. There hasn't been enough work done looking at the long-term effects. And so that's actually one of the areas of growth that needs to happen. There's some work happening for ambient air quality, and it would be ideal if we could start using some of those approaches looking at wildfire exposures, because you have individuals that live in areas that are prone to wildfire year after year. And so these kind of the cumulative exposure and the idea of the potentially long-term effects from those. But again, that's kind of the next, one of the next frontiers.
Great, thank you. I see questions in the chat. So any thoughts of working towards a combined air quality index and heat index and eventual warnings?
Yeah, it's such an interesting idea. Obviously, in the US, the EPA has the air quality index and issues air quality alerts, but it's a separate agency and infrastructure for warning about excessive heat. It's really interesting to think of how we could have a more unified sort of extreme health event or health risk warning system. I haven't heard talk about that at the government level. But scientifically, certainly there are a number of studies looking at how the effects of air pollution vary depending on temperature, and vice versa, how the effects of temperature might be modified by different background air pollution concentrations. So super interesting research area, just hasn't trickled down to policy yet.
And then our next questions is, what are some strategies for addressing the translational disconnect between the wealth of knowledge on heat and the lack of solution-based outcomes?
I think there's a lot of experimentation going on, and I think that that's good. I see a lot of innovation from several cities across the U.S. have a chief heat officer or other sort of executive branch position that's now focused on deploying solutions. More and more cities or jurisdictions have heat action plans as part of their early warning, not just early warning, but early warning and response. So I think that we're seeing a lot of innovation, and I think it's just going to take some time to figure out which of these many good ideas actually work. So does naming a heat wave give it more attention, and is that useful for reducing the health burden? Time will tell, but a lot of great innovation. So I'm optimistic that we'll land on some very practical solutions in the near future.
Yeah, and kind of in conjunction with that, with wildfires, like I mentioned, one of the approaches is to start looking at potential differences between individuals who have AC versus individuals who don't, since that's one of the main protective measures that are suggested. And so kind of along those lines, there's not a lot of information out there. So we're hoping to be able to start compiling some of that. But again, there's these common sense guidelines that are given, but not necessarily those kind of solution-based outcomes that we're looking for.
Great. And then we have another question in the chat. Given heat and wildfires are associated with some similar outcomes, are you considering joint effects, and how are you considering modeling these statistically?
So I can say, yes, we are considering it. I have a proposal looking at both the mixtures of pollutants within wildfire smoke, as well as the mixtures of extreme events like a heat wave or extreme heat and wildfire. And yeah, it's still in the process of being fully developed, but I think that would be a very helpful thing to be able to understand kind of the interplay between the two of them, and to tease out what might be contributable to one versus the other, or if there's kind of a compound effect of the co-occurrence of both of them.
Yeah, and I would just add to that, hugely important to think also about power outages, which are common under both conditions, or brownouts. And so we are now moving to in the US to living in a ever more highly engineered home environments and work environments, and relying on those systems to protect our health. And so what happens when those systems aren't available, either because it's not safe to stay home, or because it's or because there's a suspension of service due to, say, a power outage. And you can think of that in certainly in the context of wildfires, in the context of hurricanes that are obviously incredibly disruptive to infrastructure in where they make landfall, and the heat that often follows those hurricanes and other severe storms. So power outages, I think, becomes an important modifying effect as well in that context.
Yeah, agreed. And there's some work that I'm doing with folks on that California project I mentioned before, and looking at kind of the contribution of power outages to actually reducing wildfires. So kind of teasing out some of that. You reduce a wildfire, hypothetical wildfire doesn't occur, but you're turning people's AC essentially off during potentially a very hot time of the year. And so understanding kind of what's happening there will be really interesting too.
Thank you. And then we have one more question in the chat. Any experience in using wet bulb globe temperature and how it might impact thresholds for heat responses?
Yeah, we've published a paper recently on that in the Medicare work. This was some great work led by a research scientist in our group, Keith Spangler. And we had really high hopes that wet bulb globe temperature would prove to be more predictive or correlated with adverse health outcomes in a vulnerable population, because it's this composition of not just temperature, but temperature, solar radiation, wind speed, and humidity. And what we found is that it doesn't systematically perform any better or any worse than temperature or heat index. Heat index being the combination of temperature and humidity, but not including solar radiation or wind speed. And so there's been a lot of excitement, I would say, enthusiasm in the field for wet bulb globe temperature, but I'm not seeing that in the data. Of course, we're still exploring it now with the Optum emergency department visit data. Again, we haven't published that yet, but the initial results seem to show similarly, it doesn't perform systematically better or worse than any other temperature metric in terms of identifying predicting adverse health outcomes. And in some ways, I think that's a little bit lucky, because wet bulb globe temperature, I think, is harder to forecast than temperature or heat index. So I think it would have also been a challenge from an implementation point of view.
Great. I do have one question. So it kind of goes back to the scientific outcome that you were showing, Dr. Wallenius, in your research. And you were talking about the different causes of, I think it was mortality with the renal disease, or maybe no, it wasn't mortality.
Yeah, it was
with
the ED visits, but yeah.
Yes, renal disease and mental health, and the other one was respiratory outcomes. And there was a protective effect for the heat. Can you talk about that?
Yeah, I think for cardiovascular and for respiratory, we didn't see an association. I don't know if I'd consider it protective, but we didn't see an association. And, for cardiovascular, it's a little surprising, because when you look at cause-specific deaths, or studies that have looked at cause-specific deaths, do find an increased risk of cardiovascular deaths. So I think there's part of that may be outcome misclassification. So when you're talking about mortality, there's a lot of people that die for kind of old age, and those are typically assigned to cardiovascular deaths, because that's a presumed mechanism, if they don't have an overt disease that otherwise caused their death. But for ED visits, we don't have that same type of misclassification. The people that come in with cardiovascular disease actually had some cardiovascular disease manifestation. So I wonder if that's part of the difference, or part of the difference is also just the age range that we're looking at. So for studies of mortality, most people, something like 80% of people that die in the US are 65 and older. Whereas we're looking at ED visits across all ages. And of course, cardiovascular disease is less common in younger ages. So I think there's some interesting differences there. For respiratory disease, I wonder, now this is speculation, I don't have data, but also people that are prone to respiratory disease also may be behaviorally sensitive to, it's really hot out, or it's hot and humid out, I think I'm going to stay in. So there may actually be some behavior modification in response to the temperature changes amongst those that are self-described as sensitive to those conditions.
And have you done any studies, like separating the dry hot versus humid hot?
Oh, that's such a great question. So in many cities that so the way we do these studies is comparing within a city really hot days to slightly less hot days in the same city. So because weather patterns tend to be relatively consistent, so the extreme heat is dry in the Southwest and hot and humid in the Northeast. So the Northeast doesn't get a lot of very dry, super hot days. And similarly, I don't think, Phoenix gets really humid, very hot days. So the way we're looking at this, we haven't sort of figured out a way to tease that out, but that's part of this question of, would heat index perform better than temperature, or would wet bulb globe temperature perform better than ambient temperature, because it includes sort of more of these factors that we think contribute. And I think that's part of the challenge, that we're not seeing, one index sort of being uniformly better than any other.
Well, thank you so much. We are on the top of the hour, and I really appreciate your time, and both the participants and our speakers. Thank you so much, and I hope you have a great Friday and weekend.
Thank you
Thank
for
you.
hosting.
Yeah.
Thank you.